was that she had this additional work, sort of a separate life working in implementation science, which is such an important area now, I think, across medicine in general, but certainly in cancer research. So we've asked Donna to share with us her ongoing work in implementation science. So Donna, welcome.
Thanks very much, Charlie. And thank you all for being here. It's a pleasure to be here and to be able to discuss this topic with you all. So I imagine that because of the newness of implementation science, probably what I was going to start out by doing is just giving an overall introduction to the basic concepts, which is kind of at the whole other end of the cancer research spectrum. Oh, it's not on. The top switch, yeah. Okay. This might be a little better, yes. So at the whole other end of the cancer research spectrum than our previous speaker, Andrew, who was talking from the basic science end. Here's a cartoon that kind of embodies what motivated research and implementation science. It says here, the latest, wait a second. The latest research shows that we really should do something about all this research. And what we mean by this is a very famous slide in implementation science. It's called the publication pathway, and it shows that this is sort of the cascade from when, say, original research is funded, then submitted, accepted, published, appears in a bibliographic database, is taken up in reviews, guidelines, and textbooks, and actually implemented. And I think it's something like going from here, when funded research is funded, to here when positive findings are actually implemented, it's about 14% of all research it's been estimated that makes it from the research stage to the implementation stage. And it takes 17 years to get from here to there with this 14%. And so the NIH and NCI and many others have become aware of this and are very concerned that we're sinking all this money into doing all this great work, but it never is making it into public practice, the bedside, and so forth. And so implementation science is about speeding this up and increasing this percentage. So here, another sort of phrase that's common in the implementation science world is the no-do gap. And the idea is here that we know so much about how to prevent, screen, and treat, say, cancer, but yet the doing of it, there's a big gap between that knowing and that doing. And so 3 big examples in cancer. It's been found in randomized trials that probably more than 50% of colorectal cancer mortality is preventable by following the US Prevention Task Force recommendations for screening, as I'm sure many of you know. Probably 90% or more of cervical cancer is preventable through regular screening by PAP or other modalities, followed by effective high-quality treatment of abnormalities and or by HPV vaccination. And 90% of cigarette smoking is, that should say actually 90% of lung cancer is preventable by eliminating tobacco use. Yet deaths from these 3 cancers are widely prevalent in the United States, at least colorectal and lung are among our top causes of cancer incidence and mortality. And cervical cancer is the first or second leading cause of cancer incidence and mortality in most low and middle income countries around the world, in Africa, Asia, and Latin America. So this is why we say in implementation science, we have these very simple, proven interventions that could eliminate most of these cancers, yet these cancers are still the leading forms of cancer incidence and mortality. So implementation science, rather than more sort of basic science research, could be used to address many of these problems. Another example that's important is obesity. We have basically a global obesity epidemic, which is, which is leading which is leading to skyrocketing rates of diabetes, cardiovascular disease, and cancer in the US and worldwide. So NCI regards, we usually think of obesity as, you know, the leading cause of diabetes, and then somewhat to a lesser extent cardiovascular disease. But many of you probably know it's also strongly associated with colorectal cancer, endometrial cancer, and possibly other cancers. And NCI does regard the prevention and reduction of obesity as something well within the realm of what it's interested in from an implementation science perspective and otherwise. And yet there's been, again, proven interventions, the lifestyle interventions that have reduced diabetes incidence through primarily obesity reduction by 58% in the US, 29% in India, and 42% in China. And just again, to mention that the obesity epidemic is not just a problem here in the United States, where it's a very big problem, but it's also a skyrocketing problem throughout Latin America, in China, India, and other places in the world. So what, just to be a little more specific, what do we mean by implementation science? So multiple definitions have been given, and there is no one single definition that is universally agreed upon. That's the sort of correct definition, but they're all pretty much getting at the same underlying ideas, which are systematic scientific approach to ask and answer questions about how to get what works to people who need it with greater speed, fidelity, efficiency, quality, and relevant coverage. And then down here is an even simpler definition that I like a lot. Implementation science is about determining what works in real life, full-scale settings. And I'm going to elaborate on this a little bit in the following few slides. So here again is the implementation research definition. This is from a standing program announcement from the NIH, Dissemination and Implementation Research in Health, where they say implementation research is the scientific study of the use of strategies to adopt and integrate evidence-based health interventions into clinical and community settings in order to improve patient and population outcomes. And now the field has kind of evolved so that often, and certainly from an NIH perspective, they don't just even say implementation science, they say dissemination and implementation science, because it seems that it's not just enough to be able to study how to do these things, to adopt and integrate, but it's also being able to distribute those and increase the uptake at a large scale and research how that can happen. So there's this sort of sister area to implementation research called dissemination research. And so there they're talking about how to spread and sustain knowledge and associated evidence-based interventions well beyond, say, it's the study population on which an implementation research project might be conducted. So this is the way that I kind of think about this. So we know actually even before this might be some of the work that Andrew was showing and many other people here probably, which is the basic science piece. But once we get to a point where there is some kind of intervention, the first thing that usually happens is an efficacy trial. So that's usually an individually randomized controlled trial. We're very familiar with those. A great deal of biostatistics is focused on the design and analysis of RCTs, and they're usually done in sort of under the very best circumstances. Can we demonstrate the biological efficacy of a particular drug or treatment or intervention of some kind? Then the next step would be what we might call an effectiveness trial. An effectiveness trial, sometimes they're also called pragmatic trials. You might have heard that term. And from my perspective, effectiveness trials and pragmatic trials are very similar, if not the same thing. And they're usually done at a much larger scale than an efficacy trial. They're usually cluster randomized, so facilities, hospitals, clinics, practices, communities, villages would be randomized rather than individual patients. And they're usually done with much less stringent exclusion criteria, open to the whole population, open to practitioners and providers who are not necessarily at sort of elite institutions such as here, but could be throughout the community. And that's to assess whether these efficacious interventions can actually shown to be effective kind of in real life settings. And oftentimes, as many of you might know, we're disappointed in that efficacious interventions aren't shown to be effective in large-scale community-based settings. In terms of policy and adaptation, cost effectiveness is also an important aspect of this. Oftentimes there could be alternative interventions, and maybe one has been shown to be somewhat more effective, but it's much more expensive, and it might be that the overall population health could be better improved by choosing a somewhat less effective intervention that could have much wider distribution. So you can see that once I say cost effectiveness, you can see that implementation science becomes an interdisciplinary field. It doesn't just, here we might be talking about clinical people, basic scientists, and biostatisticians, but now we've brought in health economists as well, because they're the ones who have the expertise in cost effectiveness. So we've added a whole other discipline to the team. In effectiveness trials, usually the candidate intervention is compared to standard of care or some kind of placebo or control. But once the intervention passes the effectiveness and cost effectiveness test, we would move on to implementation research. So in implementation research, we don't have a control group anymore, where standard of care isn't part of the equation. We're actually comparing alternative strategies for rolling out proven interventions to ensure that they're taken up at scale with wide coverage, et cetera. And so we might be comparing, I'll show some examples, option A to option B toward implementing a certain intervention. And then finally, once the optimal strategy is found through implementation research, then the question is how to disseminate this and get it out widely across the entire population. So, these coming down from here to here to here might be things that maybe some people in the audience haven't really thought about before, but this is where, this is the space that implementation science sits. So, there are certain features of implementation and dissemination science research that that are somewhat different from, say, efficacy research and some of the antecedents to that. So, and there are things that I've had to learn about as I've moved into this implementation science world. So the first thing is theory-driven. So because we're talking about alternate strategies for uptake of proven effective interventions, it involves aspects of human behavior, health systems, organizations, financing, and so forth. And by bringing in the social scientists, they operate from sort of more of a theory-driven perspective, where they have different theories of behavioral change and organizational change. And in conceptualizing implementation and dissemination research, it's considered to be very important to have these theories featured kind of first and foremost in terms of guiding the design of the interventions. Another aspect of the research that's different is something called mixed methods research. Again, if we're concerned about, say, why did it take 17 years to get from doing this research to actually having it implemented on a wide scale, there are all sorts of barriers. There might be superstitions, there might not be the right equipment in the facilities, the providers may not be trained properly, there might be certain trepidations that patients have, and there's a certain point at which quantitative data has its limits, and it's necessary to actually talk to people. And talking to people is the realm of social scientists, and they actually have very well worked out their own rigorous methods for conducting what's called qualitative research, which involves talking to people in groups or one-on-one, recording the conversations that are structured in certain ways, transcribing the data, analyzing it, and so forth. And when we use qualitative methods along with quantitative methods in implementation research, it becomes mixed methods research. And that's an important aspect of implementation science in general. Another aspect is adaptation versus fidelity. So when I talked about implementation and dissemination here, it might be that in a complex intervention, one size may not fit all. What works in a rural health clinic in northern Maine might not work in the center of the city of New Haven. Even though we want to basically sort of get everybody who's eligible to be screened every 2 years for colorectal cancer starting from the age of 50, how we reach out to people, bring them in, follow up with them, and so forth might vary quite a bit. And that's called adaptation. If you adapt these interventions to the local context. And in implementation science, it's generally believed that context is very important. On the other hand, you don't want to change things too much, otherwise we're just talking about a whole new intervention that maybe hasn't been studied at all. So this is sort of an active area of implementation science, which is at what point does adaptation stray into infidelity? And there's not a right answer to that either. It's something actively discussed. There are working groups about it, people writing about it, and so forth. But at very least, there's general agreement that adaptation should be systematic, sort of well thought out, well recorded with good data on what the adaptations were, so that later on, if things don't work as well or they work better, it might be possible to use quantitative methods or even qualitative methods to understand what aspects of the adaptation were either useful or not so useful. Okay, so I talked about context in relation to adaptation versus fidelity. And then, of course, there's the question of external validity, which is somewhat related to maybe a possible issue with translation of the results of efficacy trials to effectiveness and beyond, in that when there's a lot of exclusion criteria and only sort of the very best doctors and health providers are rolling out the intervention, will these results be externally valid to sort of wider groups? And in general, it's often been found to not be the case. So implementation scientists are very interested in the subject of external validity and how to design studies to increase their external validity. I mentioned economic evaluation and cost effectiveness, sustainability. You can come up with great ideas. You might show that they're effective in a certain context with a lot of resources, even still, funded with research dollars. But is the intervention sustainable beyond that? Once the researchers go away, will people keep doing this? And how? And then finally, diffusion for effective interventions. It's of great interest to see, how do these spread? There can be active and passive ways of spreading. There's such a thing as certain types of index providers or index members of an intervention who could be very effective in sharing the benefits of the intervention to their peers, whether they're professional peers, friends, family, and neighbors. And these kinds of things can be incorporated into interventions. So hybrid designs is another important concept in implementation research, especially for those who are interested in designing implementation science studies and submitting them for funding, because it's actually shocking and very hard for a lot of us, myself included, although I've now gotten used to it, that if you're designing a pure implementation trial, there literally should not be a control group. It's really about comparing exploring alternative ways of implementing a proven intervention. And if a control group is added, then it starts to be called something like a hybrid type 1 design. And by hybrid, they mean it's hybrid between an implementation study and an effectiveness study. And so in a hybrid type 1 design, we're still testing the clinical intervention, that is comparing it maybe to some sort of control or standard of care, but we're also gathering information on the implementation. And then a hybrid type 3 design is sort of at the other end, where the focus is on process outcomes, like how many people were screened, what was their satisfaction with the process, and so forth. And we're not, if the cancer was prevented or treated, that would be a secondary outcome at best. And then that becomes a hybrid type 3 design, whereas a pure implementation study wouldn't even look at a health outcome at all. It would only evaluate improvements in the uptake of the proven intervention with no health outcome. And especially, let's say, the National Cancer Institute has a lot of interest right now in implementation science and a whole program on it. And I've seen this myself firsthand, when grants are written and people don't understand these distinctions, they end up getting dinged, because there are people there who really know this stuff, and you can't say you're doing implementation science and then have a primary clinical outcome compared to an intervention versus control. They would say this is not implementation science. So it's good to know about these things. Here, in terms of the models and frameworks, this is a website where you can actually, there's many of these social science theories of behavioral change and frameworks for change. And this website, you can answer certain queries and it will kind of show you a much smaller subset of potentially relevant theories of change and behavioral frameworks that might be relevant for your research. But honestly, I don't recommend this approach. I recommend anytime you're basically doing implementation science research, a social scientist really needs to be involved, and preferably one who has some background in implementation science. And they'll know all this stuff, and they'll lend that expertise to choosing the right theory and framework and making sure it's very well integrated into the research and so forth. Mixed methods, I already talked about that. And there's a whole sort of pathway in mixed methods where qualitative research can be conducted to understand barriers to uptake of a proven intervention. Then quantitative research could assess alternative implementation modes to improve process outcomes and health impacts. Qualitative research can be undertaken while ongoing to understand fidelity, meaning is the intervention being implemented as it should be, acceptability to both those delivering it as well as those receiving it, and feasibility. And then at the end, qualitative research to understand sustainability. And it's very important, I think, especially to have the ongoing qualitative research, because there's a lot of examples, unfortunately, of failed prevention trials and implementation trials. And a big study is run, a lot of money is put into it. There's no difference between the two groups, and nobody knows why. And then we're just kind of stuck, even though the intervention was already proven to be efficacious in an individually randomized trial. So we kind of know that it works, but something is happening in the implementation and at the community level that's leading to the failure. And the qualitative data can be very useful in getting a handle on that. So we're already at, is this over at 1? So well, I guess I'll skip a lot of things like dissemination research. As Charlie mentioned, I was brought in as the inaugural director of a new center at the School of Public Health, CMIPS, the Center for Methods on Implementation and Prevention Science. And our focus is exactly that, to develop methods, refine methods, and adapt methods to do this kind of work. It's an interdisciplinary center. We have 3 faculty biostatisticians. Another one is in the audience here, Shin Zhou. We have a faculty qualitative social scientist, and help wanted. We're still looking for our health economist, if anyone knows of anybody who might be suitable with an interest in strengthening methodology for empirical cost effectiveness analysis. And we have a number of other affiliated scientists at different levels and so forth. So I guess I will skip this. I will, well, this is an example I'll just quickly show you. So one of the things we're doing is looking at the impact of the Affordable Care Act on reducing colorectal cancer incidence and mortality. As you may know, colonoscopies are, at a pretty expensive prevention modality that before the Affordable Care Act, many people weren't covered for, so basically weren't getting them. And now with the Affordable Care Act, everybody is entitled to screening colonoscopies according to the US Preventive Task Force's guidelines, I think up to the age of 70. So we're looking in the Kaiser Permanente of Northern California database. There's 4 million members. We're following people between 2000 and 2017. There's about 1 million members there and 220 person months of follow-up. And we're looking to see before the ACA and then after, was there a change in colorectal cancer incidence and or mortality, which could show at a population level an impact on of the ACA. So here's a graph, and this is just showing the monthly colorectal cancer incidence rates. And then the ACA came into effect around here. And then you can see that we see this drop in rates with a lot of the usual variability that we would have in monthly rates. We're also looking at the same thing in relation to mortality. So I'll skip this. And then Charlie mentioned that I, along with Yawei Zhang, are the co-directors of the Global Oncology Initiative of the Yale Cancer Center. We're very excited about this. And one of the things we're doing, to give you an example, we won one of the pilot projects this year on cervical cancer prevention, a pilot implementation trial in Nepal. And the co-PI is Sangini Sheth, who some of you might know from the OBGYN department. And she does a lot of work on colposcopy and cervical dysplasia. So she's a perfect person to be working with us. And so to give you a sense of what an implementation science project is like, we're evaluating the implementation of a VIA cryotherapy intervention among women aged 30 to 60 in rural Nepal. And then we say evaluate. These are the things that are evaluated: acceptability, adoption, feasibility, fidelity, penetration, cost, and sustainability. And I don't have time to go over how these are measured. And then our second is to do the qualitative research and focus group discussions with people at different levels of delivery as well as receiving, the intervention. Global Oncology, we're having a seminar series, save the date. We're having Jorge Salmeron from Mexico, who's an expert in cervical cancer screening and cervical cancer screening and treatment. And then Paolo Buffetta, Associate Director for Global Oncology at Mount Sinai. And then we're having a Global Oncology Symposium on May 6th. And of course, implementation science, prevention and screening is going to feature prominently at these various events. But if anyone would like to work with us on the program committee for the Oncology Symposium, you're more than welcome. Please be in touch with me. And I guess implementation science are growing areas of research, ideally situated for cancer prevention, screening, and treatment. There's many new opportunities, and here it's a major focus, as I said, at the NCI. This is the link to the implementation science website from NCI, and then here are funding announcements at different levels for both trials as well as observational research in implementation science and cancer. So I hope this gave you a little bit of a feel for what implementation science is, what my new center is doing, and what we're trying to do in the Global Oncology program. And thanks very much for being here today.
Donna, thank you. It was a terrific summary of the work. I know we're past the hour,
Yeah.
so Donna is available to answer any questions you want to come up with.